Endocrine Audiobook for USMLE Steep 1. Now listen carefully. The thyroid diverticulum arises from the floor of the primitive pharynx and descends into the neck, and it is connected to the tongue by the thyroglossal duct, which normally disappears, but may persist as cysts or as the pyramidal lobe of the thyroid, and the foramen cecum is the normal remnant of this thyroglossal duct. You should remember this. The most common ectopic thyroid tissue site is the tongue, which we call a lingual thyroid, and its removal may result in hypothyroidism, especially if it is the only thyroid tissue present. Now let's talk about the thyroglossal duct cyst. It presents as an anterior midline neck mass, and this mass moves with swallowing or with the protrusion of the tongue, while on the other hand, a persistent cervical sinus leads to a pharyngeal cleft cyst, which is found in the lateral neck. Are you following me? Thyroid follicular cells, which are labeled as B, are derived from the endoderm, and the parafollicular cells arise from the fourth pharyngeal pouch. Now listen carefully. These are the structures you need to remember: the foramen cecum, the internal carotid artery, the external carotid artery, and the superior thyroid artery, and don't forget the hyoid bone, the thyrohyoid membrane, the thyroglossal duct, and the thyroid cartilage, as well as the thyroid gland itself, the trachea, and the brachiocephalic artery, and lastly, the inferior thyroid artery, the left subclavian artery, and the thyrocervical trunk. Now listen carefully. The pituitary gland is divided into two parts: the anterior pituitary, which we also call the adenohypophysis, and the posterior pituitary, which is known as the neurohypophysis. The anterior pituitary secretes FSH, LH, ACTH, TSH, prolactin, GH, and beta-endorphin, while melanotropin, or MSH, is secreted from the intermediate lobe of the pituitary. This anterior section is derived from oral ectoderm, which we call Rathke's pouch. The alpha subunit is a hormone subunit common to TSH, LH, FSH, and HCG, but the beta subunit determines hormone specificity. Now remember this: proopiomelanocortin, or POMC, gives rise to beta-endorphin, ACTH, and MSH, and here's a simple way to remember it: go pro with a BAM. The mnemonic flat peg helps you recall the hormones: FSH, LH, ACTH, TSH, PRL, and GH. Also note that basophils secrete FSH, LH, ACTH, and TSH, so we say B flat, and acidophils secrete prolactin and GH, giving us acid pig. Now let's talk about the posterior pituitary, or the neurohypophysis. It stores and releases vasopressin, also known as antidiuretic hormone or ADH, and oxytocin, both of which are made in the hypothalamus, specifically in the supraoptic and paraventricular nuclei. These hormones are transported to the posterior pituitary via neurophysims, which are carrier proteins, and the posterior pituitary itself is derived from neuroectoderm. So, while the anterior comes from oral ectoderm, the posterior is of neuroectodermal origin. Now listen carefully. We move on to the adrenal cortex and medulla. The adrenal cortex is derived from mesoderm, and the medulla is derived from the neural crest. Preganglionic sympathetic fibers stimulate the chromaffin cells in the adrenal medulla to secrete epinephrine and norepinephrine. In the cortex, the zona glomerulosa is regulated by angiotensin II and produces aldosterone. The zona fasciculata is regulated by ACTH and CRH and produces cortisol. The zona reticularis is also regulated by ACTH and CRH and produces DHA. So, in summary, the cortex produces mineralocorticoids, glucocorticoids, and androgens, and the medulla produces catecholamines. Here's a helpful mnemonic: GFR corresponds with salt, sugar, and sex, meaning mineralocorticoids, glucocorticoids, and androgens respectively. Now let's talk about the endocrine pancreas. The islets of Langerhans are collections of endocrine cells, specifically alpha, beta, and delta cells, and they arise from pancreatic buds. The alpha cells, found peripherally, produce glucagon. The beta cells, located centrally, produce insulin. And the delta cells, which are interspersed, produce somatostatin. These cells are situated around capillaries, with alpha, beta, and delta cells organized in a structured arrangement to carry out endocrine signaling efficiently. Are you ready? Now we move on to hypothalamic pituitary hormones. ADH increases water permeability of distal convoluted tubule and collecting duct cells in the kidney, increasing water reabsorption, and you should remember that alcohol consumption decreases ADH secretion, causing polyuria and dehydration. CRH increases ACTH, MSH, and beta-endorphin, but it is decreased in chronic glucocorticoid use. Prolactin inhibiting factor reduces prolactin and TSH, and it is commonly referred to as dopamine. Dopamine antagonists, such as antipsychotics, can cause galactorrhea due to hyperprolactinemia. Now listen closely. GHRH increases growth hormone, and its analog, tesamorelin, is used to treat HIV-associated lipodystrophy. GnRH increases FSH and LH, but it is suppressed by hyperprolactinemia. A tonic GnRH analog, like leuprolide, suppresses the hypothalamic, pituitary, gonadal axis, while pulsatile GnRH leads to puberty and fertility. MSH increases melanogenesis by melanocytes and causes hyperpigmentation in Cushing disease, since MSH and ACTH share the same precursor molecule, which is POMC. Now let's talk about oxytocin. It causes uterine contractions during labor and is responsible for the milk letdown reflex in response to suckling. It also modulates fear, anxiety, social bonding, mood, and depression. Prolactin, on the other hand, decreases GnRH and stimulates lactogenesis. Pituitary prolactinoma leads to amenorrhea, osteoporosis, hypogonadism, and galactorrhea. Breastfeeding increases prolactin, which then decreases GnRH, causing delayed postpartum ovulation, a natural form of contraception. Now listen carefully. Somatostatin decreases GH and TSH, and is also known as growth hormone inhibiting hormone, or GHIH. TRH increases TSH and prolactin, and elevated TRH, as seen in primary or secondary hypothyroidism, may increase prolactin secretion, which can lead to galactorrhea. Finally, from the hypothalamus, CRH, GnRH, TRH, somatostatin, GHRH, and dopamine all influence the anterior pituitary, which then releases ACTH and other hormones, with basophils being basophilic and acidophils being eosinophilic. Now let's talk about growth hormone, also called somatotropin, which is secreted by the anterior pituitary. It stimulates linear growth and increases muscle mass through IGF-1, also known as somatomedin C, which is secreted by the liver. It also increases insulin resistance, a diabetogenic effect. Growth hormone is released in pulses, in response to growth hormone releasing hormone, or GHRH. You should remember this. Its secretion increases during deep sleep, during hypoglycemia, during stress, and also rises during puberty and exercise. On the other hand, secretion of growth hormone decreases with aging, with obesity, with hyperglycemia, and in the presence of somatostatin, as well as somatomedin, which is a regulatory molecule secreted by the liver in response to GH acting on target tissues. Now listen carefully. Excess secretion of growth hormone, such as in the case of a pituitary adenoma, may cause acromegaly in adults or gigantism in children. Treatment involves somatostatin analogues like octreotide, or surgical removal of the tumor. Now let's go deeper into how growth hormone works. In muscle and adipose tissue it promotes amino acid uptake, it enhances protein synthesis, it decreases glucose uptake, promotes lipolysis, and in bone it also increases amino acid uptake and protein synthesis, it supports DNA and RNA synthesis. In addition, it increases the production of chondroitin sulfate and collagen, and it boosts both the size and number of cells. Now listen closely. Let's shift gears and talk about antidiuretic hormone, also known as vasopressin. It is synthesized in the hypothalamus, specifically in the supraoptic and paraventricular nuclei, and then stored and secreted by the posterior pituitary. Its primary function is to regulate serum osmolality through V2 receptors, and blood pressure through V1 receptors. So to be clear, its most important role is regulating serum osmolality, and it does this by increasing water reabsorption in the kidney, through the insertion of aquaporin channels in the principal cells of the renal collecting duct. This means that ADH decreases serum osmolality, and increases urine osmolality. Now let's talk about regulation. ADH levels increase in response to plasma osmolality, which is the primary stimulus, and also in cases of hypovolemia. In central diabetes insipidus, ADH levels are decreased. In nephrogenic diabetes insipidus, the levels are normal or increased, but the kidneys do not respond properly. Desmopressin, which is an analog of ADH, can be used to treat central diabetes insipidus and also nocturnal enuresis. Finally, you should remember that vasopressin is a potent vasopressor, which means it can be used to increase organ perfusion in septic shock. Now let's summarize the pathway. ADH is produced in the hypothalamus, stored in the posterior pituitary, and acts on the medullary collecting duct of the kidney. It regulates aquaporin channels, controls urine osmolality and urine volume, and is closely tied to serum osmolality and serum volume. Now let's explore prolactin, a hormone secreted mainly by the anterior pituitary, and structurally homologous to growth hormone. Its main function is to stimulate milk production in the breast. But it does more than that, it also inhibits ovulation in females and spermatogenesis in males. It achieves this by inhibiting the synthesis and release of GnRH, which is the gonadotropin-releasing hormone. You should remember this well. Excessive amounts of prolactin are associated with galactorrhea, amenorrhea, infertility, and even osteoporosis in females. While in males, it can lead to gynecomastia, infertility, decreased libido, and impotence. So, its effects are broad, and they impact both reproductive and sexual function in a significant way. Now listen carefully. Prolactin secretion from the anterior pituitary is tonically inhibited by dopamine, which is released from the tuberoinfundibular pathway of the hypothalamus. But here's an interesting feedback loop. Prolactin itself inhibits its own secretion by increasing dopamine synthesis and secretion from the hypothalamus. This loop ensures balance. Additionally, TRH, or thyrotrophin-releasing hormone, increases prolactin secretion, and this is particularly seen in primary or secondary hypothyroidism. However, dopamine has a stronger effect on prolactin regulation than TRH does, so dopamine remains the key player here. Now let's talk about clinical implications. Dopamine agonists like bromocriptine and cabergoline inhibit prolactin secretion, and they can be used to treat prolactinoma, which is a condition involving excessive prolactin. On the other hand, dopamine antagonists, such as most antipsychotics and medications like metoclopramide, as well as estrogens found in oral contraceptive pills or during pregnancy, all stimulate prolactin secretion. So depending on the drug, you could either suppress or enhance prolactin levels. Now are you following me? Let's dive deeper into what influences prolactin levels. Events like nipple stimulation, chest wall injury, via the autonomic nervous system, and even visual or auditory stimuli such as the sight or cry of a baby, can stimulate milk production by increasing prolactin. Higher cortical centers also play a role in this response. Estrogen, whether from medications or pregnancy, increases prolactin secretion, while hypothyroidism, both primary and secondary, can also lead to elevated prolactin through increased TRH. Lastly, reduced prolactin elimination, often influenced by liver or kidney dysfunction, can also elevate its levels. And high prolactin from any cause can lead to decreased gonadotropin-releasing hormone, which diminishes spermatogenesis and ovulation by lowering level of FSH and LH. Now let's talk about thyroid hormones. The thyroid produces triiodothyronine, which is T3, and thyroxine, which is T4. Both of these are iodine-containing hormones that control the body's metabolic rate. Are you following me? The source of these hormones is the follicles of the thyroid, and 5-deiodinase converts T4, which is the major thyroid product, into T3 in peripheral tissue. Now listen carefully. This peripheral conversion is inhibited by glucocorticoids, beta blockers, and also by propylthiouracil, or PTU. Reverse T3, also called RT3, is a metabolically inactive byproduct of T4 conversion, and its production increases in the presence of growth hormone and glucocorticoids. Now let's talk about thyroid peroxidase, which has several essential functions, including oxidation, organification of iodine, and the coupling of monoiodotyrosine (MIT) and diodotyrosine (DIT). You should remember this: thyroid peroxidase is inhibited by PTU and methimazole. And here's something to keep in mind: DIT plus DIT gives you T4, while DIT plus MIT results in T3. Another interesting point is the Wolff-Chaikoff effect, which is a protective autoregulatory mechanism where sudden exposure to excess iodine temporarily turns off thyroid peroxidase and reduces T3 and T4 production. Now listen carefully: only the free hormone is biologically active, and T3 binds to the nuclear receptor with more affinity than T4. The functions of T3 are commonly remembered using the 7 Bs. Are you ready? Brain maturation, bone growth, which works synergistically with growth hormone and IGF-1, beta-adrenergic effects which increase beta-1 receptors in the heart, leading to increased cardiac output, heart rate, stroke volume, and contractility. This is why beta blockers help reduce adrenergic symptoms in thyrotoxicosis. Also, T3 increases the basal metabolic rate by upregulating Na/Katpase, which raises oxygen consumption, respiratory rate, and body temperature. It also raises blood sugar through increased glycogenolysis and gluconeogenesis, breaks down lipids by stimulating lipolysis, and stimulates surfactant synthesis in babies. Now let's talk about regulation. TRH stimulates TSH release, which in turn stimulates follicular cells. In Graves' disease, thyroid-stimulating immunoglobulin, or TSI, also stimulates follicular cells. The negative feedback is mainly from free T3 and T4, which reduce anterior pituitary sensitivity to TRH, and also reduce TRH secretion from the hypothalamus. Thyroxine-binding globulin, or TBG, binds most of the T3 and T4 in the blood, but remember, only the free hormone is active. TBG increases during pregnancy and oral contraceptive use, because estrogen increases TBG levels, which in turn raises total T3 and T4. On the other hand, TBG levels decrease with steroid use and nephrotic syndrome. You should remember this: T3 and T4 are the only lipophilic hormones that have charged amino acids, and they require specific transporters to enter cells using facilitated diffusion. Now let's talk about parathyroid hormone. Its source is the chief cells of the parathyroid glands, and its primary function is to increase free calcium, that's Ca superscript 2, in the blood. Are you following me? It also increases calcium and phosphate, written as PO4 superscript 3, absorption from the gastrointestinal system, and enhances both calcium and phosphate release from bone through resorption. At the same time, it increases calcium reabsorption in the distal convoluted tubule, and reduces phosphate reabsorption in the proximal convoluted tubule. You should remember this: it also increases the production of 1,25-dihydroxyvitamin D3, or calcitriol, by activating the enzyme 1-alpha-hydroxylase in the proximal convoluted tubule. Think of it like this: try to make D3 in the PCT. Now listen carefully: parathyroid hormone, or PTH, raises serum calcium, lowers serum phosphate, increases urinary phosphate, and increases urinary cyclic AMP, or CMP. It also stimulates RANKL, which is the receptor activator of NF-kappa B ligand, secreted by osteoblasts and osteocytes. This binds to the RANK receptor on osteoclasts and their precursors, to stimulate osteoclast activity and increase calcium through bone resorption. Interestingly, intermittent release of PTH can actually stimulate bone formation. You should remember that. And here's a clever way to recall its phosphate effect. PTH stands for phosphate trashing hormone. Now let's talk about something related: PTH-related peptide, or PTHrP, which acts just like PTH, and is commonly elevated in malignancies, such as squamous cell carcinoma of the lung and renal cell carcinoma. Now listen carefully: the regulation of PTH is mostly driven by calcium. Low serum calcium stimulates PTH secretion. High phosphate levels also increase PTH, and so does mild magnesium deficiency. However, a severe drop in serum magnesium actually inhibits PTH secretion. Some common causes of low magnesium include diarrhea, aminoglycoside use, diuretics, and chronic alcohol use disorder. Are you ready? Calcium is the major regulator of PTH release, and vitamin D plays a role too. The feedback inhibition of PTH synthesis happens through increased levels of 1,25-dihydroxyvitamin D3. The body has 4 parathyroid glands, and together with vitamin D, PTH activity regulates calcium and phosphate balance. When PTH is released into circulation, it activates 1-alpha-hydroxylase, which converts 25-hydroxyvitamin D3 into its active form, 1,25-dihydroxyvitamin D3. This boosts calcium and phosphate absorption from the intestines and bone. So when ionized calcium drops, or phosphate rises, or when vitamin D levels change, the system adjusts by increasing or decreasing PTH accordingly. Now let's talk about plasma calcium, or Ca superscript 2, which exists in 3 main forms. Are you following me? About 45% is ionized or free, and that's the active form. Then, around 40% is bound to albumin, and about 15% is bound to anions. You should remember this: ionized or free calcium is the primary regulator of parathyroid hormone, or PTH. Changes in pH can alter PTH secretion, but changes in albumin concentration do not. This is because calcium competes with hydrogen ions, H, to bind to albumin. Now listen carefully: when pH increases, meaning there are fewer hydrogen ions, albumin binds more calcium, which lowers the ionized or free calcium level, and that can lead to symptoms like muscle cramps, pain, tingling sensations or paresthesias, and carpopedal spasms. This decrease in ionized calcium triggers an increase in PTH secretion. On the other hand, when pH decreases, meaning there are more hydrogen ions, albumin binds less calcium, resulting in more free calcium in the blood, and this suppresses PTH secretion. So the balance of pH and calcium binding plays a big role in how the body regulates parathyroid hormone. Now let's talk about calcitonin. Are you ready? It comes from the parafollicular cells, also called C cells, of the thyroid gland. Calcitonin works in opposition to PTH, but it's not very important in normal calcium homeostasis. What you should remember is this: calcitonin tones down calcium levels in the blood and helps keep calcium stored in the bones. Its main function is to reduce bone resorption. And how is it regulated? Well, increased serum calcium stimulates the secretion of calcitonin. So when blood calcium rises, calcitonin is released to bring it down, mainly by inhibiting osteoclastic bone resorption. This helps decrease the amount of calcium released from the bones into the blood. Now let's move on to glucagon, which is made by the alpha cells of the pancreas. Its function is to increase blood sugar levels, especially during fasting. It does this by promoting glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. So whenever blood glucose levels fall too low, glucagon steps in to maintain homeostasis. You should remember this: glucagon is secreted in response to hypoglycemia, or low blood sugar, and it is inhibited by insulin, amylin, somatostatin, and high blood glucose levels. Now let's talk about insulin and how it's synthesized. Are you following me? It all begins with preproinsulin, which is synthesized in the rough endoplasmic reticulum of pancreatic beta cells. Then, the pre-signal is cleaved, and this produces proinsulin. Proinsulin is stored in secretory granules, and later it's cleaved again, this time into insulin and C-peptide, which are released equally during exocytosis. Both insulin and C-peptide are elevated in conditions of endogenous insulin secretion, like in type 2 diabetes mellitus, or when insulin secretagogues are used, or in insulinoma. However, exogenous insulin lacks C-peptide, and that's an important point. It helps distinguish factitious hypoglycemia from real insulin overproduction. Insulin is synthesized in the pancreas, and it's cleared by both the liver and the kidneys. Now listen carefully: insulin binds to insulin receptors, which have tyrosine kinase activity, and this induces glucose uptake through carrier-mediated transport into insulin-dependent tissues, and also affects gene transcription. The anabolic effects of insulin include increasing glucose transport in skeletal muscle and adipose tissue, increasing glycogen synthesis and storage, increasing triglyceride synthesis, and increasing sodium retention in the kidneys. It also increases protein synthesis in muscles, increases cellular uptake of potassium and amino acids, while decreasing glucagon release and reducing lipolysis in adipose tissue. And don't forget, insulin does not cross the placenta. However, in mothers with diabetes, excess glucose can cross the placenta and stimulate excessive fetal insulin production. Now let's break down the glucose transporters, shall we? Insulin-dependent glucose transporters include GLUT4, which is found in adipose tissue and striated muscle, and exercise can also increase GLUT4 expression. Insulin-independent glucose transporters include GLUT1, found in red blood cells, the brain, cornea, and placenta, GLUT2, which is bidirectional and found in beta islet cells, the liver, kidneys, and GI tract. Think of it like a two-way street. Then there's GLUT3, in the brain and placenta, GLUT5, which transports fructose in spermatocytes and the GI tract, and finally SGLT1 and SGLT2, which are sodium-glucose cotransporters located in the kidney and small intestine. You should remember this acronym, BRIC LIPS. It stands for brain, RBCs, intestine, cornea, kidney, liver, islet, beta, cells, placenta, and spermatocytes. All of these take up glucose independently of insulin. Brain prefers glucose, but may use ketone bodies during starvation. RBCs utilize only glucose, as they lack mitochondria for aerobic metabolism. Are you ready for regulation? Glucose is the major regulator of insulin release. The insulin response is greater with oral glucose than with 4-glucose, and that's because of incretins like GLP-1 and GIP, which are released after meals and enhance beta cell sensitivity to glucose. Release of insulin is inhibited by alpha-2 stimulation and increased by beta-2 stimulation. Now listen carefully to the mechanism. Glucose enters the beta cells through GLUT2 transporters, and metabolism of glucose increases ATP production. This rise in ATP closes ATP-sensitive potassium channels, which is the target of sulfonylureas. Closing these K channels depolarizes the beta cell membrane, and that opens voltage-gated calcium channels, causing calcium influx and triggering insulin exocytosis. So to summarize the cascade, glucose enters the cell, ATP is generated, K channels close, the membrane depolarizes, calcium channels open, calcium flows in, and insulin granules are released. Then, insulin travels through the blood, binds to its receptor, activates tyrosine kinase, and leads to vesicles containing GLUT4 moving to the cell surface, increasing glucose uptake and stimulating glycogen, lipid, and protein synthesis, and even promoting cell growth and DNA synthesis. Now let's talk about the adrenal gland and the hormones it makes. Are you following me? The adrenal gland has two major parts, the medulla and the cortex itself is made of three distinct layers. The outermost is the zona glomerulosa, which produces mineralocorticoids like aldosterone. The middle layer is the zona fasciculata, which produces glucocorticoids like cortisol, and the innermost layer is the zona reticularis, which makes androgens like DHEA. Now listen carefully, it all starts from cholesterol, and the rate-limiting step involves a protein called STAR, which helps move cholesterol into the mitochondria, where it is converted to pregnenolone by the enzyme desmolase. From pregnenolone, the pathway can take many directions. One route leads to progesterone, then to 11-deoxycorticosterone, followed by corticosterone, and finally to aldosterone with the help of aldosterone synthase. Another path moves through 17-hydroxyprenolone and 17-hydroxyprogesterone, producing 11-deoxycortisol, which becomes cortisol and can be converted to cortisone. Yet another path gives rise to DHEA, then androstenedione, which can become testosterone, and finally dihydrotestosterone, DHT, through 5-alpha reductase, or estrone and estradiol via aromatase, mostly in peripheral tissues. You should remember that enzymes like 3-beta-hydroxysteroid dehydrogenase, 17-alpha-hydroxylase, 21-hydroxylase, and 11-beta-hydroxylase play critical roles at different points, and compounds like finasteride, anastrozole, letrozole, and exemestane influence these conversions. Now listen carefully as we break down the enzyme deficiencies seen in congenital adrenal hyperplasia, using 3 classic examples. First is 17-alpha-hydroxylase deficiency, where mineralocorticoids are increased, including 11-deoxycorticosterone, leading to hypertension and hypokalemia, while cortisol and sex hormones are decreased, and androstenedione is reduced. Clinically, XY individuals present with atypical genitalia and undescended testes, while XX individuals fail to develop secondary sexual characteristics. Second is the most common form, 21-hydroxylase deficiency, which causes reduced mineralocorticoids, reduced cortisol, and a rise in sex hormones, along with increased renin activity and elevated 17-hydroxyprogesterone. This condition presents in infancy with salt wasting or in childhood with precocious puberty, and in XX individuals, it causes virilization. Third is 11-beta-hydroxylase deficiency, which results in reduced aldosterone, increased 11-deoxycorticosterone, and reduced cortisol, while sex hormones and blood pressure are elevated, but renin activity is decreased. This condition can also present in infancy with severe hypertension or in childhood with precocious puberty, and XX individuals will show signs of virilization. Now listen to this final summary, because it's easy to remember. All congenital adrenal enzyme deficiencies are autosomal recessive, and most present with skin hyperpigmentation due to increased MSH, which is coproduced and secreted with ACTH. You'll also find bilateral adrenal gland enlargement, caused by increased ACTH stimulation. And here's a golden rule: if the deficient enzyme starts with a 1, it causes hypertension, and if it ends with a 1, it causes virilization in females, so make sure to memorize that. Now let's talk about cortisol, which is produced in the zona fasciculata of the adrenal cortex, and travels through the blood bound to a special protein called corticosteroid-binding globulin. Cortisol has many important functions, so listen carefully. It increases appetite, and it also raises blood pressure by upregulating alpha-1 receptors on arterioles, making them more sensitive to norepinephrine and epinephrine, which is called a permissive action. At high concentrations, cortisol can even bind to mineralocorticoid receptors, just like aldosterone. Now are you following me? Cortisol also increases insulin resistance, making it diabetogenic, and it stimulates gluconeogenesis, lipolysis, and proteolysis, while reducing glucose utilization. It also inhibits fibroblast activity, which means poor wound healing, less collagen synthesis, and more striae. Cortisol also suppresses inflammatory and immune responses, by inhibiting leukotriene and prostaglandin production, blocking white blood cell adhesion, which results in neutrophilia, and it also blocks histamine release from mast cells, causes eosinopenia and lymphopenia, and blocks IL-2 production. You should remember this, because cortisol also decreases bone formation by reducing osteoblast activity, and there's a helpful mnemonic for its effects. Cortisol is a big FIB, which stands for appetite, blood pressure, insulin resistance, gluconeogenesis, and on the other side, fibroblast activity down, inflammation down, bone formation down. But here's something important: exogenous glucocorticoids can reactivate tuberculosis and candidiasis, because they block IL-2 production. Now listen carefully. The regulation of cortisol begins in the hypothalamus, where CRH stimulates the anterior pituitary to release ACTH, which then acts on the zona fasciculata to produce cortisol. This whole system is influenced by stress and the circadian rhythm, but once cortisol levels get too high, they start to suppress CRH, ACTH, and even their own production, through negative feedback. However, chronic stress can override this system, leading to prolonged cortisol secretion, resistance to cortisol, impaired immunity, and HPA axis dysregulation. Now let's shift gears and talk about how appetite is regulated, because it's not just about cortisol. First is ghrelin, a hormone made by the stomach that stimulates hunger and promotes growth hormone release through the GH secretagogue receptor. Ghrelin levels go up during fasting, sleep deprivation, and in Prader-Willi syndrome, and here's a phrase to help you remember: ghrelin makes you grow hungry. It acts on the lateral hypothalamus, which is the brain's hunger center, to increase appetite. Then we have leptin, the satiety hormone, which is produced by adipose tissue. When there's a leptin gene mutation, it can cause severe obesity, and in people with obesity, leptin levels are high because of more adipose tissue, but unfortunately, they become tolerant or resistant to leptin's effects. Also, starvation and sleep deprivation can reduce leptin production. And here's your memory trick: leptin keeps you thin, by acting on the ventromedial hypothalamus, which is the satiety center, to decrease appetite. Finally, we can't forget the endocannabinoids, which act on receptors in both the hypothalamus and the nucleus accumbens, two brain regions that control homeostatic and reward-driven food intake, so they increase appetite, and that's why exogenous cannabinoids are known to cause the munchies. Now let's talk about the signaling pathways used by endocrine hormones, because understanding how these hormones act at the cellular level is crucial. Some hormones use CAMP as their second messenger, and here's how you can remember them: FSH, LH, ACTH, TSH, CRH, HCG, ADH acting on the V2 receptor, MSH, PTH, calcitonin, histamine on the H2 receptor, glucagon, and GHRH. That's a long list, but there's a helpful mnemonic: flat champs chug, so say it again to yourself: flat champs chug. Now listen carefully. A different group of hormones works through cGMP, including BNP, ANP, and EDRF, which is nitric oxide. These are all associated with vasodilation and diuresis, and you can remember them using the phrase bad grandpa. Think of that old grandpa helping your blood vessels relax. Now are you following me? The IP3 signaling pathway is used by GnRH, oxytocin, ADH acting on the V1 receptor, TRH, histamine on the H1 receptor, angiotensin II, and gastrin. That's another packed list, so try the mnemonic GOAT HAG. It's a strange image, but it works: GnRH, oxytocin, ADH, TRH, histamine, angiotensin II, and gastrin. Now let's switch gears and talk about hormones that act through intracellular receptors. These include the steroid hormones and thyroid hormones, like progesterone, estrogen, testosterone, cortisol, aldosterone, T3, T4, and vitamin D. All of them are lipophilic, and you can use this fun mnemonic: pet cat and TV, because these hormones can enter cells, bind to receptors inside the nucleus or cytoplasm, and then go on to influence gene transcription directly. Now listen carefully again. Some hormones signal through receptor tyrosine kinases, such as IGF-1, FGF, PDGF, EGF, and insulin. These all work via the MAP kinase pathway, and here's a trick to recall them: get found in the MAP. On the other hand, there are hormones that act through non-receptor tyrosine kinases, like GCSF, erythropoietin, thrombopoietin, prolactin, immunomodulators like cytokines, IL-2, IL-6, IFN, and also growth hormone. These hormones signal using the JAK/STAT pathway, and here's the mnemonic: get a jaked pig, to help you recall GCSF, EPO, TPO, and the rest. Now let's focus more closely on the signaling pathways of steroid hormones. Are you ready? These hormones are lipophilic, so they must circulate in the blood bound to specific binding globulins, which increase their solubility. Once they reach the target cell, they bind to receptors either in the cytoplasm or nucleus, and this receptor then transforms to expose a DNA-binding region. The complex enters the nucleus, binds to enhancer-like elements in DNA, and activates the transcription of specific genes, leading to the production of mRNA, and eventually, protein synthesis. And here's a detail you should not forget: in males, increased levels of sex hormone-binding globulin, or SHBG, lowers free testosterone, which can cause gynecomastia, while in females, decreased SHBG raises free testosterone, which can cause hirsutism. Also, increased estrogen, such as from oral contraceptives or pregnancy, can cause increased SHBG levels. Now let's talk about the syndrome of inappropriate antidiuretic hormone secretion, or SIADH. This condition is marked by excessive free water retention, but despite that, there is euvolemic hyponatremia, with continued urinary sodium excretion, and remember, urine osmolality is greater than serum osmolality. The body tries to respond to this water retention by reducing aldosterone, while increasing ANP and BNP, which leads to increased urinary sodium excretion, helping normalize extracellular fluid volume, and ultimately resulting in euvolemic hyponatremia. Now listen carefully, the treatment for SIADH begins with fluid restriction, which is the first-line intervention. If needed, salt tablets, intravenous hypertonic saline, diuretics, and ADH antagonists like conivaptan, tolvaptan, and dimeclocycline may also be used. And to help you remember the causes of SIADH, think of the mnemonic, healed up water, that's head trauma or CNS disorders, ectopic ADH such as from small cell lung cancer, exogenous hormones like vasopressin, desmopressin, or oxytocin, lung disease, and drugs, including SSRIs, carbamazepine, and cyclophosphamide. Now let's talk about ADH signaling and its dysfunction. From the posterior pituitary, ADH is stored and released. When there's SIADH, ADH levels rise, serum osmolality falls, and even though serum volume may not rise significantly, water is still retained. In the medullary collecting duct, ADH opens aquaporin channels and allows water reabsorption. In conditions like nephrogenic diabetes insipidus, ADH antagonists or drugs like lithium block this pathway. Are you following me? Now let's turn to primary polydipsia and diabetes insipidus, both central and nephrogenic forms. These are characterized by the production of large amounts of dilute urine, and possibly increased thirst. Urine-specific gravity is usually less than 1.006, and urine osmolality is typically below 300 mosm/kg. In central diabetes insipidus, which is also known as arginine vasopressin deficiency, the condition may be transient if the damage is below the hypothalamic median eminence or only affects the posterior pituitary, because ADH can still be secreted systemically. Meanwhile, nephrogenic diabetes insipidus is due to arginine vasopressin resistance. Now listen carefully, here's how they differ. In primary polydipsia, the issue is excessive water intake, leading to reduced ADH release. In central D1, there is a true deficiency of ADH, while in nephrogenic D1, there is resistance to ADH. Causes of primary polydipsia include psychiatric illnesses or lesions affecting the hypothalamic thirst center. Central DI may be idiopathic, or due to brain injury, trauma, hypoxia, tumor, surgery, or infiltrative diseases. Nephrogenic D1 can be hereditary, such as from AV2 receptor mutation, or acquired due to drugs like lithium and dimeclocycline, or electrolyte imbalances like hypercalcemia and hypokalemia. Are you ready for the lab differences? In primary polydipsia, serum osmolality is reduced, in central D1 and nephrogenic D1, it is increased. ADH levels are reduced or normal in primary polydipsia, reduced in central D1, and normal or elevated in nephrogenic D1. After water restriction testing, urine osmolality increases significantly in primary polydipsia, but shows minimal or no increase in D1, whether central or nephrogenic. And when desmopressin is given, it causes a greater than 50% increase in urine osmolality in central D1, but minimal or no change in nephrogenic D1. Now let's wrap up with treatment. For primary polydipsia, the answer is water restriction. For central D1, you use desmopressin, also called DAP. For nephrogenic D1, you manage the underlying cause, and may use a low-solute diet, hydrochlorothiazide, amiloride, or indomethacin. You should remember this, during water restriction testing, there should be no water intake for 2 to 3 hours, followed by hourly measurements of urine volume and osmolality, as well as plasma sodium and osmolality. If plasma osmolality goes above 295 to 300 mosm/kg, or serum sodium is 145 or more, or if urine osmolality doesn't increase despite rising plasma osmolality, then desmopressin is administered. Now let's talk about hypopituitarism, which is defined as the undersecretion of pituitary hormones and can occur due to several causes. These include hypothalamic disease, such as mass lesions, radiation, or infiltrative conditions, as well as pituitary surgery, and pituitary disorders, like mass effect caused by non-secreting pituitary adenomas or craniopharyngiomas. Another cause is empty sella syndrome, where the sella turcica appears empty on imaging. One important cause to remember is Sheehan syndrome, which is an ischemic infarct of the pituitary following severe postpartum hemorrhage. During pregnancy, the pituitary gland enlarges, increasing its susceptibility to hypoperfusion. The usual presentation includes failure to lactate, amenorrhea, and cold intolerance, with anterior pituitary hormones mainly affected. Treatment for hypopituitarism involves hormone replacement therapy, which may include glucocorticoids, thyroxine, sex steroids, and human growth hormone. Now listen carefully, because we're shifting to acromegaly, which is caused by excess growth hormone in adults, most commonly due to a pituitary adenoma. The findings are distinctive. There's a large tongue with deep furrows, frontal bossing, and coarsening of facial features that become more prominent with aging. Patients also develop a deep voice, excessive sweating known as diaphoresis, and hypertrophic arthropathy. There's also impaired glucose tolerance due to insulin resistance, as well as hypertension, left ventricular hypertrophy, and heart failure with preserved ejection fraction, which is the most common cause of death in these patients. If growth hormone excess happens in children, it results in gigantism, characterized by increased linear bone growth due to unfused epiphyses. Think of acromegaly in adults, and gigantism in juniors. That's a good way to remember it. Are you following me? Now for diagnosis, we begin by checking serum IGF-1 levels, because growth hormone levels fluctuate and are not reliable. A failure to suppress serum GH following an oral glucose tolerance test is diagnostic. Imaging with brain MRI typically reveals a pituitary mass. Treatment starts with surgical resection of the pituitary adenoma. If surgery doesn't achieve a cure, then medical therapy is indicated. This includes octreotide, a somatostatin analog, pegvisomant, a growth hormone receptor antagonist, or dopamine agonists, such as cabergoline. Now let's compare hypothyroidism versus hyperthyroidism, beginning with the metabolic features. In hypothyroidism, there is cold intolerance, reduced sweating, and weight gain due to a reduced basal metabolic rate and calorigenesis, along with hyponatremia from impaired free water clearance. On the other hand, in hyperthyroidism, there's heat intolerance, increased sweating, and weight loss, all due to an increased basal metabolic rate and enhanced calorigenesis, with upregulated Na/Kat-PASE. Now listen carefully to the skin and hair changes. In hypothyroidism, the skin is dry and cool due to reduced blood flow, the hair becomes coarse and brittle, and you may see diffuse alopecia, brittle nails, puffy facies, and non-pitting edema, also called myxedema, caused by increased glycosaminoglycans in interstitial spaces, which raises osmotic pressure and retains water. In contrast, hyperthyroidism presents with warm, moist skin due to vasodilation, fine hair, onycholysis, and in Graves' disease, pretibial myxedema may appear. Now let's focus on ocular findings. Hypothyroidism may cause periorbital edema, while in Graves' disease, part of hyperthyroidism, there is ophthalmopathy, including periorbital edema, exophthalmos, and lid lag or retraction. These are due to increased sympathetic stimulation of the superior tarsal muscle. Are you ready for the gastrointestinal differences? In hypothyroidism, patients often have constipation from decreased gastrointestinal motility, and reduced appetite. But in hyperthyroidism, there's hyperdification or diarrhea, increased appetite, and enhanced GI motility. Now listen carefully, because musculoskeletal symptoms differ too. Hypothyroidism can cause proximal muscle weakness, carpal tunnel syndrome, and a sign called myoedema, which is a lump that rises on a muscle when struck. Creatine kinase levels are elevated. In hyperthyroidism, there's thyrotoxic myopathy, also with proximal weakness, but CK levels are usually normal. Patients are also at risk of osteoporosis and fractures, since T3 stimulates osteoclast differentiation, increasing bone resorption and calcium release, though osteoblasts may also be affected. Let's now talk about reproductive effects. In hypothyroidism, expect abnormal uterine bleeding, reduced libido, and infertility. While in hyperthyroidism, you may still see abnormal uterine bleeding, but also gynecomastia, reduced libido, and infertility. Now let's compare neuropsychiatric findings. In hypothyroidism, there's hypoactivity, lethargy, fatigue, weakness, depressed mood, and slowed reflexes with delayed relaxation. But in hyperthyroidism, symptoms include hyperactivity, restlessness, anxiety, insomnia, fine tremors, and brisk reflexes, all due to increased beta-adrenergic activity. Finally, for the cardiovascular signs, hypothyroidism causes bradycardia and dyspnea on exertion, due to reduced cardiac output. In hyperthyroidism, you'll see tachycardia, palpitations, dyspnea, arrhythmias like atrial fibrillation, chest pain, and systolic hypertension. These happen due to increased number and sensitivity of beta-adrenergic receptors, increased expression of cardiac sarcolemmal ATPase, and reduced expression of phospholambin. Now let's end with lab findings. In hypothyroidism, you'll find elevated TSH in primary cases, reduced free T4, and hypercholesterolemia from reduced LDL receptor expression. In hyperthyroidism, there's reduced TSH if it's a primary cause, with increased free T3 and T4, and reduced LDL, HDL, and total cholesterol. Now let's talk about hypothyroidism, starting with Hashimoto thyroiditis, which is also known as chronic autoimmune thyroiditis. It is the most common cause of hypothyroidism in regions where iodine is sufficient. This condition is associated with HLA-DR3, although this association may vary by ethnic background, and it carries an increased risk of primary thyroid lymphoma, typically presenting as diffuse large B-cell lymphoma. Clinically, patients show a moderately enlarged, non-tender thyroid, and the disease may be preceded by a brief hyperthyroid phase, known as hashitoxicosis, which happens due to follicular rupture and subsequent thyroid hormone release. On serology, we find positive antithyroid peroxidase antibodies, also called antimicrosomal antibodies, and antithyroglobulin antibodies. Histologically, the thyroid shows Hürthle cells, as well as lymphoid aggregates with germinal centers. This pattern helps confirm the diagnosis. Now listen carefully, because we're moving on to postpartum thyroiditis, which is considered a mild and self-limited variant of Hashimoto thyroiditis. It usually arises less than 1 year after delivery, and the natural history follows a clear pattern. There is an initial hyperthyroid phase, typically within the first 3 months after birth, followed by hypothyroidism, and then a recovery phase leading back to a euthyroid state. It is important to recognize this timeline for proper clinical management and reassurance. Are you following me? Because now we're going into subacute granulomatous thyroiditis, also known as de Quervain thyroiditis. This is usually a self-limited condition, and its natural course progresses from transient hyperthyroidism, to a euthyroid phase, then hypothyroidism, and finally a return to the euthyroid state. It is often preceded by a viral infection, and the findings include an elevated erythrocyte sedimentation rate, jaw pain, and a very tender thyroid. Remember, de Quervain is associated with pain, which helps distinguish it from other thyroid disorders. Histologically, the gland shows granulomatous inflammation, which confirms the diagnosis. Now let's talk about a rare but notable cause, renal thyroiditis, also referred to as invasive fibrous thyroiditis. It may occur as part of the IgG4-related disease spectrum, which includes conditions like autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. Hypothyroidism occurs in about 1/3 of patients, and the extensive fibrosis may involve nearby structures, including the trachea and esophagus, potentially mimicking anaplastic carcinoma. On examination, the thyroid is slowly enlarging, very hard like a rock, fixed, and non-tender. Histology shows the thyroid being replaced by fibrous tissue and an accompanying inflammatory infiltrate, making it unique among the thyroiditis types. You should remember this next one, congenital hypothyroidism, which was formerly called cretinism. The most common cause is thyroid dysgenesis, which means abnormal development of the thyroid gland, such as agenesis, hypoplasia, or ectopy. Another major cause is dyshormonogenesis, referring to defective synthesis of thyroid hormone, often due to mutations in thyroid peroxidase, particularly in iodine-sufficient areas. Clinically, the affected infant presents with a classic pattern called the 6 Ps. The child is pot-bellied, pale, and puffy-faced, with a protruding umbilicus, a protuberant tongue, and poor brain development. Early recognition and treatment are critical to prevent permanent intellectual disability. Now listen carefully, because we're ending with other causes of hypothyroidism. Worldwide, the most common cause is iodine deficiency, and it typically presents with a goiter, as the thyroid tries to compensate. On the other hand, iodine excess can also cause hypothyroidism, due to the Wolff-Chaikoff effect, which leads to a temporary shutoff of thyroid hormone production. Certain drugs, like amiodarone and lithium, are also known culprits. Lastly, there is a condition called non-thyroidal illness syndrome, also referred to as euthyroid sick syndrome, where critically ill patients show reduced T3 levels, with normal or reduced T4 and TSH, despite no intrinsic thyroid disease. Hyperthyroidism. Now let's talk about Graves' disease, which is the most common cause of hyperthyroidism. Thyroid-stimulating immunoglobulin, which is IgG, can cause transient neonatal hyperthyroidism, and it is a type 2 hypersensitivity reaction. This immunoglobulin stimulates TSH receptors not only on the thyroid, causing hyperthyroidism and diffuse goiter, but also on dermal fibroblasts, leading to pretibial myxedema, and on orbital fibroblasts, which results in Graves' orbitopathy, and that, by the way, should be treated with glucocorticoids. Activation of T cells leads to lymphocytic infiltration of the retroorbital space, followed by increased cytokines like TNF-alpha and IFN-gamma, which then stimulate fibroblasts to secrete hydrophilic glycosaminoglycans, or GAGs. This secretion causes osmotic muscle swelling, inflammation of the muscles, and an increased number of adipocytes, all of which contribute to exophthalmos. You should remember this often presents during periods of stress, for example, pregnancy, and it is associated with the HLA-DR3 and HLA-B8 genes. Now listen carefully. Histologically, it shows tall and crowded follicular epithelial cells, along with scalloped colloid. Now let's continue with toxic multinodular goiter, which is made up of focal patches of hyperfunctioning follicular cells that are distended with colloid and are working independently of TSH. This is often due to TSH receptor mutations, found in 60% of the cases, and leads to increased release of both T3 and T4. These are seen as hot nodules, meaning hyperfunctioning areas that light up on a radioactive iodine scan, and the good news is, they are rarely malignant. Are you following me? Now let's move to thyroid storm, a rare but dangerous complication that occurs when hyperthyroidism is either incompletely treated or untreated, and then worsens significantly due to acute stress such as infection, trauma, or surgery. It presents with agitation, delirium, fever, diarrhea, coma, and even life-threatening tachyarrhythmias, which are often the cause of death. You may also see elevated liver function tests, or LFTs. The treatment involves the 4 Ps, which are beta blockers like propranolol, propylthiouracil, glucocorticoids such as prednisolone, and potassium iodide, also known as Lugol iodine. The iodide load decreases T4 synthesis through the Wolff-Chaikoff effect. Now listen carefully. There are other causes of hyperthyroidism, like exogenous thyrotoxicosis, which results from excessive intake of thyroid hormone, and you should suspect this in a patient trying to lose weight. There's also ectopic thyroid production, such as struma ovarii, and contrast-induced thyroiditis, which is called the Jod-Basedow phenomenon, along with drug-induced thyroiditis, commonly caused by medications like amiodarone and lithium. Now let's talk about the causes of goiter. When the goiter is smooth or diffuse, the causes may include Graves' disease, Hashimoto thyroiditis, iodine deficiency, and TSH-secreting pituitary adenoma. But when it is nodular, the causes include toxic multinodular goiter, thyroid adenoma, thyroid cancer, and thyroid cysts. Lastly, we come to thyroid adenoma. This is a benign, solitary growth in the thyroid gland. Most of these are non-functional, and they appear cold on a radioactive iodine scan. However, In rare cases, they can cause hyperthyroidism by autonomously producing thyroid hormone, in which case they are considered hot or toxic. The most common histologic type is follicular, and it is important to note, there is an absence of capsular or vascular invasion, which helps distinguish it from follicular carcinoma. Now let's talk about thyroid cancer, which is typically diagnosed using fine needle aspiration, and is usually treated with thyroidectomy. But you should remember, this surgery can come with important complications. One of them is hypocalcemia, which occurs due to the removal of the parathyroid glands. Another is transection of the recurrent laryngeal nerve, which can happen during ligation of the inferior thyroid artery, and this leads to dysphagia and dysphonia, which means hoarseness. There's also the risk of injuring the external branch of the superior laryngeal nerve, and this can happen during ligation of the superior thyroid vascular pedicle, potentially causing a loss of tenor, which is usually noticeable in professional voice users. Now listen carefully, papillary carcinoma is the most common type. It features empty-appearing nuclei with central clearing, known as orphan Annie eyes. It also contains psammoma bodies and nuclear grooves, and you can remember this using the phrase, Poppy and Moma adopted orphan Annie. The risk is increased with RET/PTC rearrangements, BRAF mutations, and childhood irradiation. So you should remember, papillary carcinoma is the most prevalent type, often presents with palpable lymph nodes, and has a good prognosis. Now let's move on to follicular carcinoma, which also carries a good prognosis. This one invades both the tumor capsule and the vasculature, unlike follicular adenoma, and it shows uniform follicles. It commonly spreads through the blood, or hematogenously, and is associated with RAS mutations and PX8, PPAR, gamma translocations. Keep in mind, fine needle aspiration cytology might not be able to distinguish between follicular adenoma and carcinoma. Now are you ready for the next one? Medullary carcinoma arises from parafollicular C cells, and it produces calcitonin. Histologically, it's made up of sheets of polygonal cells in an amyloid stroma, which stains with Congo red. It is associated with MEN2A and 2B syndromes, both of which involve RET mutations, and you can use this clever reminder, MEN2-Larry carcinoma. Finally, now listen carefully, undifferentiated or anaplastic carcinoma typically occurs in older patients. It presents as a rapidly enlarging neck mass, along with compressive symptoms like dyspnea, dysphagia, and hoarseness. Unfortunately, this type has a very poor prognosis. It is usually composed of pleomorphic cells that show frequent mitoses. While it may arise de novo, it most often results from dedifferentiation of a pre-existing follicular or papillary thyroid carcinoma. Now let's talk about diagnosing parathyroid disease, and to make sense of it, imagine a graph where calcium levels are shown on the horizontal axis, measured in milligrams per deciliter, starting from 4, 6, 8, and going up to 20. On the vertical axis, you have PTH or parathyroid hormone, measured in picograms per milliliter, starting at 2, 10, 50, and climbing all the way to 250. Within this plot, you'll find different zones representing various conditions. There's the normal range, then hypoparathyroidism caused by surgical resection or autoimmune destruction. Primary hyperparathyroidism shows up as high calcium and high PTH, caused by hyperplasia, adenoma, or carcinoma. Secondary hyperparathyroidism, which happens due to vitamin D deficiency, low calcium intake, or chronic kidney disease, presents with low calcium but high PTH. Then there's PTH-independent hypercalcemia, which occurs with excess calcium intake, certain cancers, or increased vitamin D levels. And finally, tertiary hyperparathyroidism, often related to chronic kidney disease, shows up with persistently high PTH even after calcium is corrected. Now listen carefully, hypoparathyroidism is usually due to injury to the parathyroid glands or their blood supply, most commonly during thyroid surgery. It can also result from autoimmune destruction or DiGeorge syndrome. The clinical findings include tetany, hypocalcemia, and hyperphosphatemia. You should remember the Chvostek sign, which is facial muscle contraction when the facial nerve is tapped, think tap the cheek. Then there's the trousseau sign, which is carpal spasm after occluding the brachial artery with a blood pressure cuff. Just remember, cuff the triceps. Now are you ready for the more complex types? Pseudohypoparathyroidism type 1A is an autosomal dominant condition, transmitted maternally, involving mutations in the imprinted GNAS gene. This gene encodes the GS protein alpha subunit, and the mutation inactivates adenylate cyclase when PTH binds to its receptor, leading to end-organ resistance, especially in the kidney and bone to the parathyroid hormone. Physical features include Albright hereditary osteodystrophy, which is marked by shortened fourth and fifth digits, along with short stature, a round face, subcutaneous calcifications, and developmental delay. Lab values in this condition show increased PTH, decreased calcium, and increased phosphate. Now let's not forget about pseudohypoparathyroidism, which is also autosomal dominant but transmitted through the paternal side. In this case, although the same GNAS gene is affected, the maternal allele is normal, which means the kidneys remain responsive to PTH. Physical findings are the same as in Albright hereditary osteodystrophy, but lab values are normal. PTH, calcium, and phosphate levels all remain within normal range. Now listen carefully, here are some key lab patterns in hypocalcemic disorders. In vitamin D deficiency, both calcium and phosphate may be normal or low. PTH is elevated, alkaline phosphatase is high, 25-hydroxy vitamin D is low, and 1,25-dihydroxy vitamin D may be low or normal. In secondary hyperparathyroidism, especially due to chronic kidney disease, calcium is low, phosphate is high, PTH and alkaline phosphatase are elevated, 25-hydroxy vitamin D is normal, and the active form, 1,25-dihydroxy vitamin D, is reduced. In classic hypoparathyroidism, calcium is low, phosphate is high, PTH is low, alkaline phosphatase is normal, while the other vitamin D values may be normal or slightly low. Finally, in pseudohypoparathyroidism, calcium is low, phosphate is high, PTH is high, alkaline phosphatase is elevated, and both forms of vitamin D may be normal or slightly low. Now let's talk about hyperparathyroidism, and we'll begin with primary hyperparathyroidism. This is usually due to a parathyroid adenoma or hyperplasia, and it leads to hypercalcemia, hypercalciuria, yes, that means kidney stones, polyuria, which they like to call thrones, and hypophosphatemia. You'll also find increased PTH, elevated ALP, and high urinary CMP. Most cases are asymptomatic, but it may present with bone pain, weakness, constipation, also known as groans, and abdominal or flank pain, which could come from kidney stones or even acute pancreatitis. You'll also see neuropsychiatric disturbances, what they call psychiatric overtones. Are you following me? Now listen carefully, because there's a classic bone manifestation you need to know: osteitis fibrosa cystica. These are cystic bone spaces filled with brown fibrous tissue, called brown tumors, made up of osteoclasts and hemosiderin from hemorrhages. This causes bone pain, and it's due to elevated PTH, most classically associated with primary hyperparathyroidism, but it can also be seen in secondary cases. So remember this phrase, it's important: stones, thrones, bones, groans, and psychiatric overtones. Next, we move on to secondary hyperparathyroidism, which involves secondary hyperplasia due to decreased calcium absorption and/or increased phosphate, most often from chronic kidney disease. This disease leads to hypovitaminosis D and hyperphosphatemia, which then reduces calcium. So you'll see hypocalcemia and hyperphosphatemia in chronic kidney disease, and this is in contrast to hypophosphatemia seen in most other causes. ALP and PTH levels will be increased too. And don't forget renal osteodystrophy, which results from secondary and even tertiary hyperparathyroidism, and causes bone lesions. Are you ready for the next one? Let's discuss tertiary hyperparathyroidism. This is a refractory, or autonomous, form of hyperparathyroidism that results from end-stage renal disease. In this case, PTH levels are very high, and calcium levels are also elevated. Finally, you should remember familial hypocalciuric hypercalcemia, an autosomal dominant condition. It involves defective G-protein-coupled calcium-sensing receptors, found in multiple tissues like the parathyroids and kidneys. Because of this, higher than normal calcium levels are needed to suppress PTH. This leads to excessive renal calcium reabsorption, causing mild hypercalcemia and hypocalciuria, with PTH levels that are either normal or slightly increased. Now listen carefully. Diabetes mellitus presents with acute signs that are easy to remember, such as polydipsia, which means excessive thirst, polyuria, meaning frequent urination, and polyphagia, or increased hunger. These are commonly referred to as the 3Ps. Along with these, patients may experience weight loss. In type 1 diabetes, a dangerous complication called diabetic ketoacidosis, or DKA, can develop, while in type 2, a different but equally serious condition called the hyperosmolar hyperglycemic state may occur. Rarely, diabetes can result from unopposed secretion of hormones like growth hormone and epinephrine. And, you should also remember this, individuals receiving long-term glucocorticoid therapy, such as steroids, can develop what's known as steroid diabetes. Now let's talk about the chronic complications, which are mainly due to non-enzymatic glycation. In small vessels, this leads to hyaline arteriolosclerosis, which causes issues like retinopathy, neuropathy, and nephropathy. In large vessels, glycation contributes to atherosclerosis, and that's why patients are at high risk for coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Keep in mind, myocardial infarction, or heart attack, is the most common cause of death in diabetic patients. Now listen carefully. There's also something called osmotic damage, which happens when sorbitol builds up in organs that contain aldose reductase but either lack or have very little sorbitol dehydrogenase. This type of damage results in various types of neuropathy, motor and sensory types, often in a glove and stocking pattern, and also autonomic dysfunction, which can show up as gastroesophageal reflux, delayed stomach emptying or gastroparesis, and diabetic diarrhea. And let's not forget, sorbitol buildup can also lead to cataracts. Are you following me? Now let's review how diabetes is diagnosed. One important test is HbA1c, a value equal to or above 6.5% confirms diabetes. This test reflects the average blood glucose over the past 3 months and is affected by red blood cell turnover. Fasting plasma glucose, if it's 126 mg per deciliter or higher after more than 8 hours of fasting, also meets the diagnostic threshold. Another method is the 2-hour oral glucose tolerance test, a value of 200 mg per deciliter or more, 2 hours after drinking 75 grams of glucose in water, is considered diagnostic. And finally, if a random plasma glucose level is 200 mg per deciliter or more, and the person shows symptoms of hyperglycemia, then that too confirms diabetes. Now listen carefully. In the absence of insulin, several processes are triggered. Lipolysis breaks down fats, proteolysis breaks down proteins, and gluconeogenesis along with glycogenolysis increases glucose production, while tissue uptake of glucose decreases. As a result, blood sugar levels rise, and free fatty acids in the plasma increase. This leads to weight loss and reduced muscle mass. The liver starts making ketones, resulting in ketonemia and ketonuria, which can cause vomiting. An anion gap metabolic acidosis develops, and this may trigger hyperventilation or Kussmaul breathing, a deep and labored type of respiration. Now let's summarize the consequences. Osmotic diuresis increases plasma osmolality and leads to the loss of water, sodium, and potassium. This causes intense thirst, hypovolemia, and eventually circulatory collapse, resulting in poor tissue perfusion. Are you ready? Let's start by comparing type 1 and type 2 diabetes mellitus. In type 1, the primary defect is an autoimmune process, where T cells destroy the pancreatic beta cells. You might see islet cell cytoplasmic antibodies, antiglutamic acid decarboxylase antibodies, or insulin autoantibodies. These are often present. But in type 2, the main problem is resistance to insulin, which gradually leads to the failure of pancreatic beta cells. Now listen carefully, insulin is always necessary in the treatment of type 1 diabetes, but only sometimes required in type 2. Type 1 usually begins before the age of 30, while type 2 typically starts after age 40, although exceptions are common in both cases. Type 1 has no association with obesity, but type 2 often is linked to obesity. When it comes to genetics, type 1 has a relatively weak genetic predisposition, with about 50% concordance in identical twins, and it's polygenic in nature. On the other hand, type 2 has a much stronger genetic link, with up to 90% concordance in identical twins, and is also polygenic. Type 1 is associated with certain HLA types, specifically HLA-DR4 and HLA-DR3, and as a mnemonic, for -3 equals type 1. But type 2 has no HLA association. Now let's compare glucose tolerance and insulin sensitivity. In type 1, glucose intolerance is severe, and insulin sensitivity is high. In type 2, glucose intolerance is only mild to moderate, and insulin sensitivity is low. Ketoacidosis is common in type 1, but rare in type 2. Beta cell numbers in the islets are reduced in type 1, but in type 2 they can vary and may include amyloid deposits. Serum insulin levels are low in type 1, while in type 2 they may be high at first, but drop as the disease progresses. Classic symptoms, including polydipsia, polyuria, polyphagia, and weight loss, are common in type 1, but only sometimes seen in type 2. Are you following me? Histologically, type 1 is characterized by leukocytic infiltration of the islets, while type 2 shows deposits of islet amyloid polypeptide. When we talk about hyperglycemic emergencies, remember that diabetic ketoacidosis, or DKA, is seen in type 1, while the hyperosmolar hyperglycemic state, or HHS, is more typical in type 2. Now let's talk about the pathogenesis. DKA is often triggered by insulin noncompliance, or increased insulin demand due to stress, like an infection. This leads to increased lipolysis and oxidation of free fatty acids, producing excess ketone bodies, specifically, beta-hydroxybutyrate and acetoacetate. In DKA, insulin is deficient and ketones are present. Meanwhile, HHS involves profound hyperglycemia that causes massive osmotic diuresis, resulting in dehydration and increased serum osmolality. It's classically seen in older patients with type 2 diabetes who have a limited ability to drink fluids. In HHS, insulin is still present, and ketones are either low or absent. Now listen carefully, DKA has deadly signs and symptoms, including delirium or psychosis, rapid and deep breathing known as Kussmaul respirations, abdominal pain, nausea, vomiting, and dehydration. A fruity odor on the breath, caused by exhaled acetone, is another telltale sign. On the other hand, HHS may present with extreme thirst, polyuria, lethargy, focal neurologic deficits, and sometimes seizures. Let's go through the lab findings. In DKA, you'll find hyperglycemia, increased hydrogen ion concentration, and decreased bicarbonate, indicating a high anion gap metabolic acidosis. Urine and blood ketone levels are elevated, and there is leukocytosis. Serum potassium may be normal or increased, but intracellular potassium is depleted because of a shift out of the cells, triggered by low insulin and acidosis. Osmotic diuresis leads to even more potassium being lost in the urine, which results in total body potassium depletion. In contrast, lab findings in HHS show severe hyperglycemia, often over 600 mg per deciliter, elevated serum osmolality above 320 milliosmoles per kilogram, and a normal pH, meaning there is no acidosis. There are no ketones, and potassium levels may be normal or high in the blood, but intracellular potassium is still decreased. You should remember this. Complications of DKA include life-threatening infections like mucormycosis, cerebral edema, and cardiac arrhythmias. Without treatment, both DKA and HHS can lead to coma or death. Treatment for both conditions includes intravenous fluids, intravenous insulin, and potassium, to restore intracellular stores. And don't forget, glucose may be needed during insulin therapy to prevent hypoglycemia. Now let's talk about hypoglycemia in diabetes mellitus. This usually occurs in patients who are treated with insulin, or with insulin secretagogues, such as sulfonylureas and meglitinides. It typically happens in the context of high-dose treatment, inadequate food intake, or physical exercise. You should remember, there are two types of symptoms, neurogenic and neuroglycopenic. Neurogenic symptoms, also called autonomic symptoms, include diaphoresis, which means sweating, tachycardia, or fast heart rate, tremor, anxiety, and hunger. These signs allow the person to perceive that glucose levels are dropping. This is called hypoglycemia awareness. But now listen carefully, neuroglycopenic symptoms involve the central nervous system. These include altered mental status, seizures, and even death, which results from insufficient glucose reaching the brain. These symptoms can occur without the earlier neurogenic warning signs, especially in patients who have a reduced autonomic response, for example, those taking beta blockers. This situation is called hypoglycemia unawareness. So, how do you treat it? The treatment includes simple carbohydrates, like glucose tablets or fruit juice, and in more severe cases, intramuscular glucagon or intravenous dextrose may be necessary. Are you following me? Now let's turn to Cushing's syndrome. This condition is caused by increased levels of cortisol, which can arise from various sources. The most common cause is exogenous glucocorticoids, where cortisol levels rise, but ACTH levels fall, leading to bilateral adrenal atrophy. Another cause is a primary adrenal adenoma, hyperplasia, or carcinoma, again causing reduced ACTH and atrophy of the uninvolved adrenal gland. But there's more, ACTH-secreting pituitary adenomas, known as Cushing disease, or paraneoplastic ACTH secretion, such as from small cell lung cancer or bronchial carcinoids, lead to bilateral adrenal hyperplasia. Among these, Cushing disease is responsible for the majority of endogenous cases. Now listen carefully, the clinical findings of Cushing syndrome can be remembered with the phrase moon facies. This stands for metabolic syndrome, which includes hypertension, hyperglycemia, and hyperlipidemia, obesity, particularly truncal weight gain with wasting of the limbs, a round face, or moon facies, and a dorsocervical fat pad, often called a buffalo hump. There is also osteoporosis, neuropsychiatric symptoms, like depression, anxiety, and irritability, facial plethora, androgen excess, leading to acne and hirsutism, cataracts, immunosuppression, ecchymosis, or easy bruising, and finally, skin changes, including thinning, striae, and sometimes hyperpigmentation. Are you ready for diagnosis? Screening tests include measuring elevated free cortisol on a 24-hour urinalysis, increased late-night salivary cortisol, and checking for a lack of suppression on the overnight low-dose dexamethasone test. Now pay attention, the next step is to measure serum ACTH. If ACTH is suppressed, then the case is ACTH-independent Cushing syndrome, which points to either exogenous glucocorticoid use or an adrenal tumor, and in that case, adrenal CT should be done to confirm the diagnosis. But if ACTH is not suppressed, then we're dealing with ACTH-dependent Cushing syndrome. If that's suspected, you should proceed with an MRI of the pituitary to look for a pituitary adenoma, which would confirm Cushing disease. If no pituitary tumor is seen, or if another source is suspected, then a CT of the chest, abdomen, or pelvis should be done to identify possible ectopic ACTH-secreting tumors. In such cases, further confirmation may require a high-dose dexamethasone suppression test or a CRH stimulation test to distinguish between Cushing disease and ectopic ACTH secretion. Now listen carefully, adrenal insufficiency is the inability of the adrenal glands to generate enough glucocorticoids, and sometimes mineralocorticoids, to meet the body's needs. This condition can be either acute or chronic. Common symptoms include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, gastrointestinal disturbances, and even sugar or salt cravings. The treatment, as you should remember, involves glucocorticoid replacement, and in some cases, mineralocorticoid replacement as well. Are you following me? Let's start with primary adrenal insufficiency. This occurs when there's a reduction in gland function, leading to decreased cortisol and aldosterone levels. As a result, patients experience hypotension due to hyponatremic volume contraction, hyperkalemia, and metabolic acidosis. One distinctive feature is hyperpigmentation of the skin and mucosal areas, especially in pressure points and the buccal mucosa. Now let's talk about the mechanism. When cortisol levels drop, negative feedback on the pituitary is reduced, which causes an increase in production of POMC derivatives, such as beta-endorphin, ACTH, and MSH. This leads to increased melanin synthesis because of elevated MSH, which is why primary adrenal insufficiency results in visible skin and mucosal pigmentation. Addison disease is the classic example of chronic primary adrenal insufficiency. It is usually caused by adrenal atrophy or destruction. In high-income countries, the most common cause is autoimmune adrenalitis, while in low-income countries, tuberculosis is more often responsible. Now let's shift to secondary and tertiary adrenal insufficiency. These conditions occur due to decreased ACTH secretion from the pituitary, that's secondary, or decreased CRH secretion from the hypothalamus, that's tertiary. Importantly, there's no hyperkalemia here, because aldosterone synthesis remains intact thanks to a functioning adrenal gland and an intact renin-angiotensin-aldosterone system. Also, there is no hyperpigmentation, since ACTH and MSH levels are not elevated. You should remember, secondary adrenal insufficiency usually results from pituitary diseases, while tertiary adrenal insufficiency most commonly follows the abrupt discontinuation of chronic glucocorticoid therapy, due to suppression of the hypothalamic pituitary adrenal axis. Now let's discuss acute adrenal insufficiency, also known as adrenal crisis or Addisonian crisis. This life-threatening condition is often triggered by acute stressors, like infection, which increase the body's demand for glucocorticoids. It typically occurs in patients who already have adrenal insufficiency or those on chronic glucocorticoid therapy. The presentation can include sudden abdominal pain, nausea, vomiting, altered mental status, and shock. Are you ready for a special case? Waterhouse-Friderichsen syndrome is another acute cause. It involves bilateral adrenal hemorrhage, often in the context of severe sepsis, such as meningococcemia. This results in acute primary adrenal insufficiency and can be rapidly fatal if not treated promptly. Now listen carefully. The diagnostic approach starts with checking an early morning cortisol level, or performing an ACTH stimulation test. If adrenal insufficiency is suspected, you measure random serum ACTH to determine the type. If ACTH is decreased or inappropriately normal, then you are likely dealing with secondary or tertiary adrenal insufficiency. But if ACTH is elevated, the diagnosis is primary adrenal insufficiency. In either case, if AM cortisol is low, and the peak cortisol response to stimulation is also low, that confirms the diagnosis. Now listen carefully. Hyperaldosteronism refers to increased secretion of aldosterone from the adrenal gland. The clinical features include hypertension, low or normal potassium levels, and metabolic alkalosis. One key point you should remember is that primary hyperaldosteronism doesn't directly cause edema, and that's because of the aldosterone escape mechanism. However, in certain secondary causes of hyperaldosteronism, such as heart failure, this escape mechanism becomes impaired, which leads to worsening edema. Let's go deeper into primary hyperaldosteronism, which is most often seen in patients with bilateral adrenal hyperplasia or an adrenal adenoma, also called Conn syndrome. These patients typically have increased aldosterone levels, but decreased renin. The result is treatment-resistant hypertension, which can be difficult to manage without addressing the underlying cause. Are you ready for the secondary type? In secondary hyperaldosteronism, both aldosterone and renin levels are elevated. It's usually found in patients with renovascular hypertension, or in those with renin-producing tumors of the juxtaglomerular cells. It also occurs in conditions with edema, like cirrhosis, heart failure, or nephrotic syndrome. Now let's shift gears, and talk about neuroendocrine tumors. These are a heterogeneous group of neoplasms that originate from neuroendocrine cells, cells that share characteristics of both nerve cells and hormone-producing cells. Most of these tumors occur in the gastrointestinal system, such as carcinoid tumors or gastrinomas. Others arise in the pancreas, like insulinomas and glucagenomas, or in the lungs, like small cell carcinoma. You can also find them in the thyroid, like medullary carcinoma, and in the adrenal glands, like pheochromocytoma. These neuroendocrine cells, including pancreatic beta cells and enterochromaffin cells, all share a common function through an enzyme system called amine precursor uptake decarboxylase, or APUD. Despite their differences in embryologic origin, location, and what they secrete, they typically produce markers like chromogranin A, neuron-specific enolase, synaptophysin, serotonin, histamine, and calcitonin. And as for the treatment, surgical resection is the main approach, sometimes combined with somatostatin analogs. Now let's talk about neuroblastoma. Are you following me? This is the most common solid extracranial tumor in children, usually affecting those under 4 years old. It generally arises in the adrenal medulla, but it can also appear anywhere along the sympathetic chain. Neuroblastoma originates from neural crest cells and has a few key distinguishing features. First, the most common presentation includes abdominal distension and a firm, irregular mass that crosses the midline, unlike Wilms tumor, which is smooth and found on just one side. And unlike pheochromocytoma, neuroblastoma is usually normotensive, meaning it doesn't typically cause high blood pressure. You should remember this too. It can also present with a rare neurological finding called opsoclonus myoclonus syndrome, sometimes described as dancing eyes, dancing feet. Lab tests show elevated catecholamine metabolites, namely HVA and VMA, in the urine. Histologically, you'll find homocyte rosettes, clusters of neuroblasts surrounding a central area of neuropil, which are characteristic of both neuroblastoma and medulloblastoma. Last but not least, neuroblastomas test positive for bombesin and neuron-specific enolase, and are associated with amplification of the NMYC oncogene, which carries prognostic significance. Now let's talk about pheochromocytoma, the most common tumor of the adrenal medulla in adults. It's derived from chromaffin cells, which arise from the neural crest, and though it's rare, it may be associated with germline mutations like NF1, VHL, and RD, seen in men 2A and 2B. You should remember the classic rule of 10 for pheochromocytoma: 10% are malignant, 10% bilateral, 10% extraadrenal such as paragangliomas in the bladder wall or the organ of Zuckerkandl, 10% calcify, and 10% occur in children. Most of these tumors secrete epinephrine, norepinephrine, and dopamine, which can cause episodic hypertension, and may also secrete EPO, leading to polycythemia. These symptoms typically occur in spells, meaning they relapse and remit, and include episodic hyperadrenergic symptoms known as the 5 Ps, pressure, meaning increased blood pressure, pain in the form of headaches, perspiration, palpitations or tachycardia, and pallor. Now listen carefully. The findings include increased catecholamines and metanephrines like homovanillic acid and vanillomandelic acid in urine and plasma, and though uncommon, episodic hyperglycemia may also be seen. These tumors are positive for chromogranin, synaptophysin, and neuron-specific enolase. Treatment requires irreversible alpha antagonists such as phenoxybenzamine, followed by beta blockers prior to tumor resection, and this order is crucial. Alpha blockade must be achieved before giving beta blockers to avoid a hypertensive crisis, remember, A before B. And to help you recall, just think, phenoxybenzamine for pheochromocytoma. Are you following me? Now let's explore multiple endocrine neoplasias, also known as men's syndromes, which all have autosomal dominant inheritance. Just like the X-men are dominant over villains, these syndromes are powerful. MEN1 includes pituitary tumors, either prolactin or GH secreting, pancreatic endocrine tumors such as those seen in Zollinger-Ellison syndrome, insulinomas, VI palmas, and glucagenomas which are rare, and parathyroid adenomas. MEN1 is associated with a mutation of the MEN1 tumor suppressor gene, which codes for menin on chromosome 11, and may also present with angiofibromas, cholangiomas, and meningiomas. Now let's talk MEN2A and MEN2B. MEN2A includes parathyroid hyperplasia, medullary thyroid carcinoma, which is a neoplasm of parafollicular C cells that secretes calcitonin, thus requiring prophylactic thyroidectomy, and pheochromocytoma, which secretes catecholamines. MEN2A is associated with a mutation in the RET proto-oncogene, which codes for a receptor tyrosine kinase on chromosome 10. MEN2B, on the other hand, includes medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas, which can appear in the oral or intestinal mucosa. It's associated with a marfanoid habitus and also with a mutation in the RET gene. You can remember the pattern. MEN1 has 3 Ps, pituitary, pancreas, parathyroid. MEN2A has 2 Ps and 1 M, parathyroid, pheochromocytoma, medullary carcinoma, while MEN2B has 1 P and 2 Ms, pheochromocytoma, medullary carcinoma, mucosal neuromas. Now let's go to pancreatic islet cell tumors, and we'll begin with insulinoma. This is a tumor of pancreatic beta cells that causes overproduction of insulin, leading to hypoglycemia. You may see what's called the Whipple triad: low blood glucose, symptoms of hypoglycemia like lethargy, syncope, or diplopia, and resolution of symptoms after glucose levels are normalized. Symptomatic patients typically show low blood glucose and high C-peptide levels, distinguishing it from exogenous insulin use. Around 10% of cases are associated with MEN1 syndrome, and the treatment is surgical resection. Glucagonoma, on the other hand, is a tumor of pancreatic alpha cells that leads to overproduction of glucagon and presents with the 6 Ds, dermatitis, often as necrolytic migratory erythema, diabetes or hyperglycemia, deep vein thrombosis, declining weight, depression, and diarrhea. The treatment involves octreotide and surgical resection. Now listen carefully. Somatostatinoma is a tumor of pancreatic delta cells that causes overproduction of somatostatin. This suppresses secretion of several key hormones and substances including secretin, cholecystokinin, glucagon, insulin, gastrin, and gastric inhibitory peptide. As a result, patients may present with diabetes or glucose intolerance, steatorrhea, gallstones, and achlorhydria. Treatment includes surgical resection, and symptom control with somatostatin analogues like octreotide. Now let's talk carcinoid tumors. These arise from neuroendocrine cells and are most commonly found in the intestine or the lung. These cells secrete serotonin, or 5-HT, which normally undergoes hepatic first-pass metabolism and breakdown by monoamine oxidase in the lung. But here's the key point: if serotonin reaches the systemic circulation, such as after liver metastasis, the carcinoid tumor may present with carcinoid syndrome. This includes episodic flushing, diarrhea, wheezing, and right-sided valvular heart disease like tricuspid regurgitation or pulmonic stenosis. You'll also find elevated urinary 5-HIAA levels. Excess serotonin production can deplete tryptophan stores, resulting in niacin deficiency and leading to pellagra. Histologically, carcinoid tumors form rosettes and are positive for chromogranin A and synaptophysin. Diagnosis is made by increased 24-hour urinary excretion of 5-HIAA, and tumor localization and staging can be done with octreotide scintigraphy. Treatment includes surgical resection, somatostatin analogues like octreotide, or tryptophan hydroxylase inhibitors such as teletristat. Remember the rule of thirds: 1/3 metastasize, 1/3 present with a second malignancy, and 1/3 are multiple. Finally, let's talk about Zollinger-Ellison syndrome, which refers to a constellation of symptoms resulting from acid hypersecretion due to a gastrin-secreting tumor, or gastrinoma, found most often in the duodenum or pancreas. This leads to single or multiple recurrent ulcers in the duodenum or jejunum, and these are often refractory to proton pump inhibitors. The excess acid causes malabsorption by inactivating pancreatic enzymes in the small bowel. Patients present with abdominal pain, heartburn, diarrhea or steatorrhea, and weight loss. A positive secretin stimulation test, which shows increased gastrin levels after secretin administration, normally an inhibitor, confirms the diagnosis. Chromogranin A is also positive, and Zollinger-Ellison syndrome may be associated with MEN1. Now let's talk about diabetes mellitus therapy, where all patients should first receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment, of course, depends on the type of diabetes and the level of glycemic control. For type 1 diabetes mellitus, the mainstay is insulin replacement. For type 2 diabetes mellitus, therapy includes oral agents, with metformin as the first-line choice, along with non-insulin injectables and sometimes insulin replacement. Weight loss is especially helpful in lowering blood glucose. For gestational diabetes mellitus, insulin replacement is used when nutrition therapy and exercise alone are not enough. Regular, or short-acting insulin, is the preferred option for diabetic ketoacidosis given via intravenous, also for hyperkalemia when paired with glucose to prevent hypoglycemia, and for stress-induced hyperglycemia. Are you following me? Now let's look at how the drugs act across different organs. Metformin and pioglitazone improve insulin sensitivity in adipose tissue and skeletal muscle, while also reducing glucose production in the liver. SGLT2 inhibitors act on the kidney by decreasing glucose reabsorption. Alpha-glucosidase inhibitors act in the intestine by reducing glucose absorption. GLP-1 analogs, DPP-4 inhibitors, and amylin analogs work on the stomach to slow gastric emptying and act on pancreatic alpha cells to reduce glucagon release. Sulfonylureas, meglitinides, GLP-1 analogs, and DPP-4 inhibitors also act on pancreatic beta cells to stimulate insulin secretion. Now listen carefully, insulin preparations come in different types with varying durations. The rapid-acting insulins, with no lag, include Lispro, Aspart, and Glolacine. The short-acting insulin is regular insulin. The intermediate-acting insulin is NPH. Long-acting insulins include Detamir and Glargine. And the very long-acting insulin is Degludec. These insulin preparations bind to the insulin receptor, which has tyrosine kinase activity. In the liver, they increase glucose storage as glycogen. In the muscle, they promote glycogen formation and protein synthesis. In fat, they increase triglyceride storage. And at the cell membrane level, they increase potassium uptake. Now you should remember this, while these insulin types differ in onset and duration, they share similar side effects. These include hypoglycemia, lipodystrophy, rare hypersensitivity reactions, and weight gain. So, always consider the timing and dosing carefully to balance efficacy and safety when managing diabetes pharmacologically. Now let's talk about drugs that increase insulin sensitivity. Metformin works by inhibiting mitochondrial glycerol 3-phosphate dehydrogenase, also known as MGPD. This leads to the inhibition of hepatic gluconeogenesis and blocks the action of glucagon. It also increases glycolysis and enhances peripheral glucose uptake, which means it increases insulin sensitivity. Side effects include gastrointestinal upset and lactic acidosis, particularly in patients with renal insufficiency, cirrhosis, sepsis, or hypoperfusion. It may also cause vitamin B12 deficiency. But, one beneficial effect is weight loss, which is often desired. Now listen carefully. Pioglitazone activates PPAR-gamma, which is a nuclear receptor. This activation increases insulin sensitivity and levels of adiponectin. It also leads to better regulation of glucose metabolism and fatty acid storage. However, it may cause weight gain, edema, and heart failure, and it increases the risk of fractures. Also, remember, its onset of action is delayed, taking several weeks to show full effect. Are you following me? Now we move to drugs that increase insulin secretion. First-generation sulfonylureas like chlorpropamide and tolbutamide, and second-generation sulfonylureas like glipizide and glyburide, work by closing potassium channels in pancreatic beta cell membranes. This causes cell depolarization, which leads to insulin release through an increase in calcium influx. The first-generation drugs may cause a disulfiram-like reaction, though they are rarely used. All sulfonylureas may cause hypoglycemia, especially in patients with renal insufficiency, and they can cause weight gain. Meglitinides like nataglinide and repaglinide increase glucose-induced insulin secretion similarly. You should remember this: GLP-1 analogues like exenatide, liraglutide, and semaglutide reduce glucagon release, delay gastric emptying, and increase glucose-dependent insulin release. They may cause nausea, vomiting, and pancreatitis, but they also promote weight loss and increase satiety, both of which are often desired. DPP-4 inhibitors like linagliptin, saxagliptin, and sitagliptin inhibit the DPP-4 enzyme that deactivates GLP-1, which again leads to reduced glucagon release and delayed gastric emptying, with increased glucose-dependent insulin release. These drugs may cause respiratory and urinary infections, are weight neutral, and also increase satiety. Now let's talk about decreasing glucose absorption. Sodium glucose cotransporter 2 inhibitors, such as canagliflozin, dapagliflozin, and empagliflozin, block the reabsorption of glucose in the proximal convoluted tubule, leading to glucosuria. They also cause natriuresis and osmotic diuresis, which in turn lowers blood glucose, serum sodium, extracellular fluid volume, and blood pressure. Side effects include glucosuria, which can lead to urinary tract infections and vulvovaginal candidiasis, dehydration resulting in orthostatic hypotension, and weight loss. These drugs should be used cautiously in patients with renal insufficiency, as their efficacy declines with lower GFR. Now listen carefully: alpha-glucosidase inhibitors like acarbose and miglitol inhibit intestinal brush border alpha-glucosidases, which leads to delayed carbohydrate hydrolysis and glucose absorption, ultimately reducing postprandial hyperglycemia. However, they can cause gastrointestinal upset and bloating, and they are not recommended in renal insufficiency. You should also remember amylin analogues like pramlintide, which reduce glucagon release and gastric emptying. They can cause hypoglycemia and nausea, but they also increase satiety, which is often beneficial. Now let's switch gears and discuss thionamides. Propylthiouracil and methimazole block thyroid peroxidase, inhibiting the oxidation of iodide as well as the organification and coupling of iodine, which leads to the inhibition of thyroid hormone synthesis. In addition, propylthiouracil blocks 5'-deiodinase, decreasing peripheral conversion of T4 to T3. These are used in hyperthyroidism. PTU is used in the first trimester of pregnancy due to the teratogenicity of methimazole, while methimazole is used in the second and third trimesters to avoid PTU-induced hepatotoxicity. Neither is used to treat Graves' ophthalmopathy, which is managed with glucocorticoids. Side effects include skin rash, agranulocytosis, aplastic anemia, and hepatotoxicity. PTU is associated with ANCA-positive vasculitis, and methimazole can cause aplasia cutis, making it a possible teratogen. Now listen carefully: levothyroxine and liothyronine are hormone replacements for T4 and T3, respectively. Levothyroxine, which has 4 letters like T4, and liothyronine, which has 3 letters like T3, are used to treat hypothyroidism and myxedema. However, they can be misused for weight loss. It's important to avoid using levothyroxine alongside antacids, bile acid resins, or ferrous sulfate, as these reduce absorption. To distinguish exogenous from endogenous hyperthyroidism, one should use TSH receptor antibodies, radioactive iodine uptake, or thyroid blood flow on ultrasound. Side effects may include tachycardia, heat intolerance, tremors, and arrhythmias. Now are you ready for hypothalamic and pituitary drugs? Conivaptan and tolvaptan are ADH antagonists used in SIAD to block ADH action at the V2 receptor. Dimeclocycline is also an ADH antagonist and a tetracycline, used for the same purpose. Desmopressin is an ADH analog, useful in central diabetes insipidus, von Willebrand disease, sleep enuresis, and hemophilia. Growth hormone is used in GH deficiency and Turner syndrome. Oxytocin is used to induce labor and control uterine hemorrhage. Octreotide, a somatostatin analog, treats acromegaly, carcinoid syndrome, gastrinoma, glucagonoma, and esophageal varices. Now let's wrap up with a few other important agents. Fludrocortisone is a synthetic analog of aldosterone with glucocorticoid effects. It helps retain fluid and is used in primary adrenal insufficiency. Its side effects are similar to those of glucocorticoids, but also include edema, heart failure exacerbation, and hyperpigmentation. Cinacalcet, which you can pronounce as senacalcet, sensitizes the calcium-sensing receptor in the parathyroid gland to circulating calcium, reducing PTH levels. It's used in secondary hyperparathyroidism in chronic kidney disease patients on dialysis, in primary hyperparathyroidism when surgery fails, and in parathyroid carcinoma. It may cause hypocalcemia. Sevelamer is a non-absorbable phosphate binder that prevents phosphate absorption from the GI tract and is used in hyperphosphatemia in CKD. Side effects include hypophosphatemia and GI upset. Finally, listen carefully. Cation exchange resins like potyramer, sodium polystyrene sulfonate, and zirconium cyclosilicate bind potassium in the colon in exchange for sodium or calcium, promoting potassium excretion in feces. They are used in hyperkalemia, and may cause hypokalemia and GI upset.